Hello, welcome everyone to our very first briefing of Protect Our Province, British Columbia. My name is Dr. Amy Tan and I will be facilitating this first webinar. I am a family physician and a palliative care physician. At first, I would like to start with a land acknowledgement. Considering that we are all across the province, I do want to acknowledge that Protect Our Province, BC, acknowledges that our work takes place on the traditional, unceded, and stolen territories belonging to many different Indigenous peoples in the place that we now call British Columbia. Unceded means that Indigenous title to the land has never been surrendered or relinquished. A map of the First Nations territory is available from the BC Assembly of First Nations. Now I would like to have Dr. Karina Zeidler give a message as one of the co-founders of Protect Our Province, BC, and I will take it away after that.
Hello, everyone. Thank you so much for joining us today. My name is Karina Zeidler. I am a family physician in Vancouver, speaking to you from the unceded traditional territory of the Musqueam, Squamish, and Tsleil-Waututh Nations. I am thrilled to introduce the first of our Protect Our Province BC COVID-19 briefings. And before we get started, I wanted to share a little bit about who we are and why we're doing this. So PoP BC is a grassroots group of physicians, nurses, health scientists, and community organizers. We were inspired by the Protect Our Province Alberta group, who've been giving regular COVID-19 updates on the catastrophic situation over there and providing excellent information on a variety of topics related to COVID-19. So we wanted to be able to offer something similar to the people of BC. Why? Because we, although we all desperately want for this pandemic to be over, we're just not there yet. We're still in the midst of our fourth wave, and if we compare where we're at now to last year, same time, we have 6 times more hospitalizations, I think like 8 times more ICU admissions, and 11 times more deaths. We had 93 deaths just in the last 2 weeks. Our acute care staff are exhausted and traumatized and burnt out, and our kids still are not well enough protected in school. So we're still in trouble. And what our group has noticed is that there is this growing disconnect between some of what the government is telling us about the pandemic and the virus and how it works, and what people are hearing and seeing from other sources. So our intention with these briefings is to try to fill some of that gap by sharing some of the most up-to-date evidence-based science on COVID-19 as presented by people with various expertise, such as those that are here today, and in future also invite people to share their lived experiences as it relates to the topic of our briefings. The idea is to empower people with that knowledge so that we can all better protect ourselves and our loved ones, as well as to keep pushing our government for answers and hopefully more meaningful action to help prevent unnecessary death or disability from COVID-19. There will be dedicated time at the end of each briefing for questions for media and the public, and we'll be regularly updating our website at protectbc.ca with what we hope will be useful information for you. Last of all, I do want to emphasize that we are a nonpartisan group. We're not affiliated with any political party. We don't get any funding or sponsorship money from anybody, and we're all volunteers. who are just dedicating their time to making these briefings happen. So without further ado, we'll get the show on the road, and I'll go back to you, Dr. Tan.
Thank you very much, Dr. Zeidler. So the first thing we'd like to do is to give you context for where we are going with regards to what our group is seeing with the current situation of COVID-19 in British Columbia across the province. And so we'll do that first, and then we will then speak with our experts with regards to this today's theme, which is that aerosol transmission is key. So I'm going to ask that this be put to my first slide, please. And if not, oh, perfect. Okay. So this is slides, and I do want to acknowledge and thank the people in our group who are the modeling experts who have compiled these slides. And I do want to show that these are the rates of cases over the last 7 days in the different health authorities in British Columbia. And what I mean by rate is the number of cases per 100,000 people. So it gives you an ability to compare one region to another. And so you can see that it's very interesting that Vancouver Island is actually very similar to Fraser Health, which I think is surprising us because of how populated Fraser Health is compared to the island, as an example of something to just point out. The other thing is that Vancouver Coastal has been pretty much percolating at quite a low rate with this most current wave. But what we can see is interior health has been affected, and perhaps because of the regional measures that were put in place in the summer, there is now a decline in their case rate. But what we're seeing in Northern Health, unfortunately, is a fourfold increase compared to the rest of the province with regards to the cases. Next slide, please. What this translates to, unfortunately, in this fourth wave is the 10 to 14-day lagging indicator, as we call it, of hospitalizations, because what hospitalizations are usually take about 10 days to actually take effect from being diagnosed. And what you can see here is that Northern Health is unfortunately incredibly stressed right now as a healthcare system. What this means, and we don't have the ability to actually narrow this down into ICU numbers, but what we see here is how dire the situation is with regards to the healthcare system and the ability to deliver care, not only to those who have COVID-19, but any other illness that requires people to seek medical care now is going to be affected simply because there's only so many hospital beds and ICU beds and personnel to take care of patients. And we've seen in recent weeks that there have been transfers of patients from Northern Health to other health authorities, namely Fraser and Vancouver Island, to help support this. And so the one point that I want to underscore here is that what happens in one health region absolutely affects our entire province with regards to what we are able to deliver as a province to take care of the patients that we have everywhere over the province. Next slide, please. And then this, unfortunately, then also relates to higher case rates mean higher hospitalizations and higher deaths, unfortunately. We are not seeing that decoupling that we thought we would see at this stage in the pandemic with regards to vaccinations. We are still seeing, unfortunately, people getting very sick. And unfortunately, because of a combination of younger people perhaps not being fully protected with vaccinations, younger people are actually being quite affected. But we're also seeing elderly people in long-term care again being affected by being, even despite being double vaccinated, that their protection might be not as complete as we had hoped. And so unfortunately, we continue to see outbreaks and deaths with regards to that. Next slide, please. The next and the last point that I would just like to make is that this is a slide, and thank you to Dr. Jens von Bergman for compiling this. And this shows 10 years and under, which is the orange looking line, and adults or 10 years and over in BC is the green line. And what you can see in September after school started, the cases for kids who are all unvaccinated simply because of their age and the fact that they're not yet approved for the vaccine really increased significantly in September. It sounds and looks like it's perhaps decreasing, and we're not quite sure yet. We need to wait and see and continue to observe, but it may be that there's more stringent masking. We know that masking from K to 3 was instituted a couple of weeks ago. That might be contributing as well. And we know that there's many factors that could be affecting this. But the interesting thing, and the one thing I wanted to point out, is that this is the population right now that is still depending on the non-vaccine modes of prevention. And this then leads to us talking about the aerosol transmission of the virus that causes COVID-19 and what perhaps we can do as a community to protect ourselves and our loved ones and our greater community in schools, in workplaces, until we actually are able to vaccinate up to 90% of the population. But we still are finding that because of Delta, we do need to put these other preventative measures in. So without further ado, I do want to introduce our first speaker, and he is Dr. Victor Leung, who is an infectious disease physician and a medical microbiologist specializing in infection prevention and control and antimicrobial stewardship. Thank you so much for agreeing to share your expertise with British Columbia, and we look forward to hearing what you have to say. Thank you.
Hi, thank you. Thanks for the opportunity to speak as a guest speaker. I'll just wait for the slides to pop up. So I'm going to take this opportunity to speak to you about the science of transmission of SARS-CoV-2. Next slide, please. So for full disclosures, I am a volunteer speaker for Protect Our Province BC. I'm not part of the organizers, but I've been invited today to speak about transmission of SARS-CoV-2 from the perspective of an infectious disease physician and medical microbiologist who has been involved in direct patient care as well as in planning for interventions at some hospital levels. I am a member of Masks for Canada, which is a grassroots organization composed of multiple disciplines, advocating for the importance of high quality masks as well as other non-pharmaceutical interventions throughout this pandemic. And I'm an advocate for This Is Our Shot Canada, which is a vaccination campaign throughout Canada to inspire vaccine confidence for those who should be getting vaccinated as soon as possible if they haven't been already. Now, the focus of my talk is going to be on education. It primarily stemmed from acknowledging that I have made a mistake in understanding transmission when this pandemic first occurred. And from that mistake, I think it's important to realize that that's an opportunity to learn. I own that mistake, and I'm taking this opportunity to share with you and tell the story of some of the learnings I've had, but in a way that is up to date and based on the most recent evidence of transmission of SARS-CoV-2, the virus that causes COVID-19. Next slide, please. So the outline is referencing a bit about transmission and different modes of transmission and the terminology around that, but also focusing on this terminology on droplets and aerosols, why that is so important. Review the evidence that airborne transmission is the predominant mode of transmission for SARS-CoV-2. And then to summarize the measures that we have to mitigate transmission of this. And the following speaker after me will speak about some of the engineering aspects in a bit more detail. Next slide. So if we go back to February 11th, 2020, WHO has a press conference talking about this emerging virus. And the Director General, during one of his questions, stated without doubt that this is airborne. He said, "Corona is airborne." A few minutes later, and towards the second part of the conference, you can see Dr. Mike Ryan writing some notes, and shortly after that, the Director General speaks about transmission again and wants to clarify that what he meant to say is that this is transmitted through droplets and is through respiratory transmission. And I think this set the stage in terms of an important point in this timeline that led to us and led to many of us be biased. And this bias, this anchoring bias, was quite strong throughout the pandemic until subsequent events when other individuals in specialists in aerosol science, atmospheric chemistry, engineering started to question why that was stated and the importance of clarifying modes of transmission, because everything we do depends on understanding the modes of transmission in terms of resources allocated to what can be done to prevent transmission. Now, this anchoring bias that is from this news event wasn't a single time point in history. And in fact, in medicine and in infectious diseases and public health, there has been misunderstandings of modes of transmission due to some key events throughout history related to how diseases were transmitted. So if we look back to diseases like cholera, malaria, or puerperal fever associated with group A strep, we used to think that those were all transmitted through some form in the air. And that was not well characterized until we later on realized that cholera was mainly transmitted through fecally contaminated water, puerperal fever through unclean hands of healthcare workers during delivery, and malaria through vectors like mosquitoes. So the importance of understanding transmission has a long history, and with droplets and airborne, I would refer you to a link that I've posted, or I've asked the organizers to post, on the historical aspects of the droplet dogma, which is what we know now. And if we look at diseases like tuberculosis, it wasn't recognized that it was airborne until there was animal studies showing this in 1962. And even with diseases that are now well recognized as airborne, like measles, it wasn't officially recognized by the scientific community until 1980s through epidemiologic studies. Next slide. So before I go into the factors of transmission, I think it's important to review the various stages of COVID infection. And if we look at the figure on the right, the y-axis, vertical axis, is representation of the SARS-CoV-2 viral load in an infected individual. And the x-axis on the horizontal is time. Now, when someone is exposed to this virus, they do not necessarily have high amounts of virus in them at that point. The virus requires binding and replication and uses the human host to do this. And with time, there is significant virus that is produced to a point where someone is considered highly infectious. With some more time, the virus load decreases, and the residual symptoms that a person has can be in their post-infectious phase. We know that this time point, if visualized on a log scale, is a very short time point in that we can see the virus dramatically increasing to trillions of copies over a short time point and then rapidly decreasing again. But the symptoms that we see in patients don't necessarily correlate well with the viral load. And when people are in the community and infected, they may have no symptoms, yet still be infectious, as we see during that pre-symptomatic phase, when they can be shedding virus in variable amounts and contributing to transmission of infection. And we now know that this asymptomatic transmission is very significant. And one of the difficulties in controlling the virus is that people are contributing to transmission before they know they are sick. And some people never have detectable symptoms, so they can continue to shed virus. But after a period of about 7 days, that dramatically decreases unless we have very immunocompromised hosts or a very specific group that can have prolonged viral replication. When people are sick enough to be admitted to hospital, their variability in whether they're infectious is also quite different because people's response to the virus is variable. And oftentimes, by the time someone goes into the intensive care unit and is intubated, requiring life support, at that point, they may not be very infectious at all based on how viral replication works and the human response to this infection. Most of their manifestations of the disease are due to the human inflammatory response as a way to combat this virus. And transmission is not as simple as one person who is infected will transmit to multiple people. In fact, we know that this virus and the ability to transmit is overly dispersed, with some individuals transmitting to lots of individuals, while others may be dead-end infections without contributing to further transmission. And this type of exposure will be dependent on the risk of exposure to infection will be dependent on the concentration of virus a person is exposed to and the time for which they are exposed to that virus. This is going to be dependent on environmental factors, how much virus is emitted, as well as host factors. So with that understanding, I think we can now go on to modes of transmission. Next slide, please. So this is from an excellent review that's also been posted by P.Eng and colleagues, published in Science, on airborne transmission of respiratory diseases. And what I want you to focus on first is looking at someone who is infected and then the person beside them, which is a potential host. When we have someone who's infected, they are constantly expelling virus into the environment through normal physiologic activities such as breathing, speaking, singing, shouting, coughing, and sneezing, for example. And the host can be in variable proximity to an infected person, yet still get infected. And when we look at the three main modes of transmission when talking about respiratory viruses, we think of airborne or transmission through aerosols, droplets, directly transmission through direct impact of these droplets, and fomites, which is through direct contact with somebody, through touch, or direct contact with inanimate surfaces that have live and virus on them that can then be inoculated through the respiratory tract or mucosal membranes in order to cause the infection in the host. It's important to recognize from this figure now what we mean by aerosols and droplets. So aerosols are particles that are either liquid, solid, or in semi-solid states that are suspended in the air. And the reason they're suspended in the air and can float and stay suspended beyond 1 meter has to do with their particle size and the physical properties of these aerosols. We used to think in the medical textbooks and guidelines that have been repeated, and the source is found in the historical document that reviews the history of droplet dogma that I've posted online. We used to think that 5 micrometers was the cutoff. So this 5 micrometer cutoff ended up being in textbooks, making us think that aerosols were only important if they were less than 5 micrometers. But we now know that aerosols can be variable sizes up to 100 micrometers. And with particles up to 100 micrometers, they can too be suspended in the air for a prolonged period of time, meaning that someone who enters a room after an infectious person has left it is still possible to inhale these aerosols. Now, these aerosols will land in different parts of different parts of the human host with small aerosols, those less than 5 micrometers, making it down to the bronchioles and the alveoli in the lungs, the lower respiratory tract. And those particles that are larger, larger aerosols between 5 to 100 microns are all inhalable as well, but they land in different spots. So larger particles of the aerosols will land in the nasopharynx, where the swab is often done to sample for this virus, or it could land in the main bronchus in the upper airways. However, when we talk about droplets, these droplets are not inhalable. These droplets cause infection through direct contact with mucosal surfaces of the nose, through the eyes, and through the mouth. And then through that can cause infection. But we know that the probability of droplets causing infection is much lower, purely because of some of the physical properties. Large droplets will drop to the ground within close proximity to an individual and not stay suspended in the air to allow for infection through direct impact on the mucosal surfaces. And if we look at the concentration of these of these particles, if you're close to someone who is infectious, the concentration of aerosols are much more significant than the concentration of droplets, which quickly fall to the ground. And so if we look at the next slide and think about the phases of infection or transmission, first of all, in phase 1, someone needs to be able to generate significant particles that are infectious into the air. We know that those droplets then will fall to the ground quickly within 1 meter in most settings. Whereas these aerosols can be transported in the airspace and be affected by environmental factors, namely the temperature of the environment, the relative humidity, airflow, how much air exchanges there are, and how much fresh air is brought in through ventilation, as well as UV radiation. So in outdoor settings where we have UV, or in facilities where you may have upper room germicidal radiation, that can also help with decreasing infectious aerosols being transported into the airspace. And then the third phase is finally inhalation and deposition of these infectious particles, most of which are aerosols. And so if we go to the next slide, we can see that a quick summary or an analogy that's not a perfect analogy, but I think illustrates it quite well, is that aerosols travel like smoke. And so when you are close to a person, we call those short range aerosols, and therefore you have a higher probability of smelling and seeing the smoke. If you are distant from a person, you still may be able to see the smoke and smell it, and that smoke will stay suspended in the air and for longer periods of time in poorly ventilated spaces. Next slide. Whereas droplets are really like missiles. They're ballistic. They drop to the ground quickly because of their large size, and don't play a significant part in contribution as much as aerosols. Whereas contact or inanimate surfaces really play a minimal role. And in terms of epidemiologic studies or other evidence supporting droplet and contact modes of transmission, it's very minimal compared to the evidence we now have for aerosol transmission. Next slide, please. So there is, in this review article, representative evidence of airborne transmission for multiple different types of viruses. This article specifically looks at respiratory viruses such as SARS-1 or SARS-CoV, MERS, SARS-CoV-2, and you can see that SARS-CoV-2 evidence, in terms of the different levels of evidence, really predominate to give us a true understanding how this is transmitted. It's important now that as we go into influenza season, much of the literature, if we look back in history and the studies, support a significant role for airborne transmission of influenza virus as well. And we have other viruses like rhinovirus, measles virus, and respiratory syncytial virus. At the beginning, there was quite a bit of confusion, people saying that it's not as infectious as measles, or we don't have the evidence to support this as airborne transmission. But if we look at measles virus, there is, in fact, less evidence in the various modes of evidence that we have that show that measles is airborne. So this high bar that was set in the infectious diseases, public health, medical fields, to say that you need a certain level of evidence to show that this is airborne, SARS-CoV-2 has achieved that, and has achieved that above many of the viruses that we, or many of the pathogens that we now treat as airborne. Next slide, please. So this paper from Tricia Greenhalgh and colleagues, published in The Lancet, summarizes back in May the 10 scientific reasons in support of airborne transmission of SARS-CoV-2. Again, this is on the website, so I'll let you read that. But I will speak briefly to the 10 points. We know that this virus causes transmission, significantly driving this pandemic through super spreading events, with some events resulting in multiple, numerous individuals getting infected and then transmitting further on. And when we look closely at how these super spreading events occurred, only aerosol transmission can plausibly explain some of this transmission. We also have evidence of long-range transmission in quarantine hotels, for example, where careful investigation through closed-circuit television and other epidemiologic forms of investigation have shown that this is not through droplets or direct contact. Because SARS-CoV-2 does transmit through asymptomatic transmission, people who are not coughing or sneezing and simply just breathing and talking are contributing to aerosols in the environment that lead to subsequent transmission. Transmission rates, we know, are much higher indoors than they are outdoors, primarily explained by the high degree of ventilation we have in the outdoor environment. And in hospital-associated or healthcare-associated infections, otherwise known as nosocomial infections, careful documentation and strict adherence to contact and droplet personal protective equipment has not been able to decrease this exposure. Similarly, viable virus has been detected in the air, and we have animal evidence as well as a lack of evidence supporting droplet and fomite overall. Next slide, please. I know, sorry, I'm going a little over time, so I will try to speed up the next part. So to summarize, I think to recognize the main modes of transmission, or naming it to tame it, is very important, because if you can identify and acknowledge how this is transmitted, you won't have to go through as much uncertainty or anxiety. You can act on it, and you can act on it by making interventions that improve ventilation and improve filtration, because these are most important in cleaning the air and reducing aerosols. Wearing a fitted mask, recognizing that face shields and plexiglass alone actually don't improve things, and in fact can worsen things by trapping aerosols in a space, avoiding crowded indoor locations, and focusing less on disinfecting surfaces. It doesn't mean we don't have to for other purposes, but the emphasis on disinfecting surfaces should be reallocated to cleaning the air. And in healthcare facility settings, we can think about ways we can reduce infection in current state as well as in future hospital builds, such as increasing and using only single rooms, having experts assess and optimize heating, ventilation, air conditioning systems. In the short term, we can install portable HEPA units or equivalents that work in cleaning the air, as well as wearing fitted respirators in the right setting. Next slide, please. Masks. The three most important things to think about are filtration, fit, and function. We know that poorly fitting masks, such as the one illustrated here, have many gaps to the side and the bottom, at the top. This results in leakage of aerosols. It doesn't mean that they're not effective, but they're not effective as a well-fitted mask. Next slide. And so well-fitted masks can come in different forms, but the form that I use and people can use in public are N95 respirators that are tightly fitted. They filter out large particles and small particles, and also the most difficult to filter particles, which are those that are in the size of around 3 micrometers, and they do so at 95% efficiency. Next slide. So Masks for Canada has some information. It's a grassroots group. We're not supporting one manufacturer over the other, but it does refer you to different places where you can purchase masks and gives you instructions on thinking about filter fit and functionality. Next slide. Finally, I think this is when we're talking about learning and ways people understand information. I think people absorb information, learn about it in different ways. And I think this cartoon illustration that's very well done by the Aerosol Science Research Center and the authors of the article in the Science review paper on respiratory viruses is accessible, I think, to many different age groups and helps explain and visualize the importance of recognizing airborne transmission and acknowledging what we need to do to prevent its further, to mitigate transmission of airborne diseases. Thank you.
Thank you very much, Dr. Lim. That was so informative. And I loved your phrase, name it to tame it. And so we're naming the aerosol transmission to help people in BC protect themselves. And so we're going to go from naming it and why we're naming it as aerosols to how to tame it, in addition to what has just been discussed with regards to better fitting masks and better functioning masks. And so I am delighted to introduce Michelle Naef, who is a professional mechanical engineer registered with the APEGA and a PhD candidate in process safety and risk management. And she will be talking about, again, ventilation and the science and the engineering behind all of this. So welcome, and thank you so much for agreeing to present to our webinar audience.
Thank you very much. I really appreciate it. Hello, and hello to everyone in the chat. I do have a presentation. I think, is that going to come up?
It should. Just give us a sec.
Okay. I'm here, as Drs. Tan and Long mentioned, to talk about ventilation and airborne contaminants. I found in my background, I worked as an engineer in heavy industry, that heating, ventilation, and air conditioning are often neglected by people who use buildings, live in buildings, and even sometimes own buildings. So if we can go to the next slide, please. There's a really great way to talk about heating, ventilation, and air conditioning, or HVAC, that most people are probably already familiar with. And that's if you think about a car. And so what you start to realize when you play around with the climate controls in a car, no matter what age or technology is in your car, you start to realize that the airflow, the heating, and if you're lucky enough to have cooling in the form of air conditioning, those are all dependent concepts. And even in a car, you can see that there are multiple sources of energy and mass, particularly gas flow, even in this relatively simple single box. So there are, when you expand that up into a large building, particularly large commercial buildings, the systems become quite complicated. And there are a lot of simplifications and assumptions that we can make that lead to good building hygiene and that can significantly reduce the presence of airborne contaminants and more specifically, the amount of time that people are exposed to them when they're occupying the space. So we can go on to the next slide. Thank you. So this button is probably familiar to most people who've been driving. There are two key concepts that I want to talk about in terms of reducing contaminants. The first one is referred to as air changes, and that's the process of ventilation. So ventilation is any natural or can be a mechanically induced movement of air in and out of a space. And we call the space that we're considering at any given time a control volume. The deal with the ventilation is the contaminants that are suspended in the air can be removed, even if the sources are still in there. So we can be moving our contaminated air through continuously, and that will reduce the accumulation of contaminant that the people are exposed to. There are two key ways that you can increase ventilation, and excessively simplified, these are to increase the amount of fresh air makeup coming in, or to increase the rate at which you are forcing air out of the space. And I'll call that exhaust for now. The other type of mechanical ventilation that is relevant to the reduction of contaminants and exposure is circulation. So circulation, it can be accomplished with differences in temperature in the air, but generally the way we're going to be able to achieve it is with mechanical fans or air movers. And those accelerate air and cause it to circulate inside the space. The contaminants will continue to accumulate in the space as long as the sources are still there. But by mixing the contaminant in with the clean air that's sort of everywhere else, it is effectively diluted. So the breathing space around each person you can dramatically reduce the amount of contaminants in there just by circulating the air. So ways that you can use circulation to reduce the effects of accumulation are what I'll call in-loop filtration. So that would be something like what we're talking about with portable HEPA filter units. That is typically going to be a type of circulation where we take the contaminated air and run it through a filter and then eject it back into the space. One way that you can manipulate how effective that is by changing the amount of power that you have, whether it's one fan, whether it's a built-in fan, or you're adding maybe a few mechanical devices. So if we can go on to the next slide, please. So when we take our kind of car example up and scale it up into the great indoors, what you can do as an individual or a person who owns a building, maybe as like an occupational health type of specialist, is you want to break your indoor space into digestible chunks. Typically that's on a room basis, but sometimes you do need to group a couple of rooms together. And the way you're going to break up this space is to identify the sources of fresh air, as well as the outlets or returns. There's a lot of different names for them. But you want to get some idea of all the inlets and all the outlets of the space. And there's a small diagram. I included some calculations there just for reference. But that's what we're talking about when we're talking about air changes per hour. It's an approximation based on the rate of gas flow in all of the inlets and the rate of gas flow in all of the outlets that will allow us to estimate roughly how often we completely replace the gas molecules in the room. And air change per hour is frequently, it's a little bit easier to visualize than just reporting like a flow rate in or out. So we know that the CDC has given a recommendation of 6 air changes per hour to sort of, really excel at airborne contaminant reduction. And a more typical value that you'd expect in sort of a comfortable indoor space, you're probably looking at getting about 2 or 3 air changes per hour. So there's a little bit of a gap there if we're trying to use our HVAC systems to reduce exposure to pathogens. We're going to want to look at ways to increase the amount of air changes per hour. There are a lot of choices that you can make in risk management, and it's really important to approach it in an intentional way and to identify your goals up at the front. And it's also really important that you collect some real information about the situation you're dealing with. So there are commercial buildings, usually new ones, where the ventilation system is heavily automated and likely already includes some inline filtration. That type of system it can relatively inexpensively be optimized for airflow. And that may be a wise investment for some businesses and some spaces because you can significantly reduce the exposure to contaminants by changing the control settings for that HVAC unit. Other buildings are in a completely different situation, right? They don't have automated control, they don't have inline filtration, and there's a general stuffiness, at multiple times a year that's indicating to us we're probably not getting a high quality airflow. So there are some simple tests that you can do to assess the air quality in your space. The first one, typically you'll probably want to hire a mechanical contractor or an engineering firm to do this. It's a very quick test. It's relatively inexpensive. You can measure the airflow at multiple places throughout your building. And to perform this test in typical elementary school would take an hour at most 2. So this is a really, really good way to increase your confidence about the air quality in your space, is to measure the airflow at different locations and then get that mechanical contractor to give you a report on your airflow performance. Sort of a second measurement that gives us a more complete insight is going to be to measure the accumulation of contaminants. We don't measure airborne virus. Sorry, there's a fire alarm here. I may have to go. But we want to measure contaminants. And so what we do is we measure CO2 as a proxy. And CO2 monitors are inexpensive and can be used by almost anyone. I am very sorry. I have to evacuate my building.
All right. Well, I'm sorry, and this is what happens with a live broadcast. So thank you so much,
sorry.
and I hope it is a false alarm, but we do need to make sure you have safety. So because safety is our middle name, and we're about protecting people, please, we will have to catch up with you. But we appreciate everything you've shared already, and the car analogy is just perfect. And we will hopefully be able to put up some more resources with regards to the remaining part of your slides. So thank you so much. Take care. All right. So thank you, Dr. Long. I hope you're safe and not anywhere where there's some alarm going off right now. So hopefully you can join us for the Q&A, and Dr. Zeidler's back on as well. So at this time, I think we will start with some questions, and we just wanted to know if there were any media who wanted to ask a question at this time.
I'm just going to jump in here and say that, yes, we do have journalists that want to ask questions. We were hoping to have them come into the broadcast studio. We might just need a moment to sort out that technical difficulty. I'm going to go fade back into the background.
Okay. Okay. Thank you. So in the meantime, I was wondering if I could actually, we actually have crowdsourced some questions prior to the session. So I was wondering if there could be some questions that we could maybe ask right now before the media are able to ask our questions. So Dr. Ling, after talking about aerosols and how it is spread, question that's come up is if COVID is transmitted via aerosol, as we've now learned from your excellent presentation, how is this being addressed in the hospital? How is this being addressed in open spaces where, similar to Michelle Naef's presentation, where we're talking about defining your space? And if you can't define your space, how are these, things like emerge departments or hospital wards? How is this being addressed in places where COVID-19 patients are actually going for care?
Yeah, so there is one slide that I didn't show in the presentation, which is the safety science perspective, looking at various interventions we have to reduce risk. Because this, in terms of transmission, it's all probabilistic. And the chances of exposure to infection are going to be based on multiple factors. And so in, say, for example, a healthcare environment, it'll depend largely on what is happening in the community that's going into the healthcare environment at that time. So I'll give you an example. If in a healthcare facility that might be older and hasn't necessarily been able to achieve the highest standards for the HVAC system to meet ventilation and filtration standards as specified by the Canadian Standards Association or the American Society of Refrigerating Heating Engineers, or ASHRAE, that can result in a poor ventilation, poor filtration of the air. but we can still reduce the risk by understanding what the context is on that ward. So for example, if we identify suddenly that someone who's been hospitalized on a hospital ward is having symptoms and is determined to be COVID, and they were COVID negative on admission. So 7 days ago, for example, they were negative. It suggests that at this point you have probable hospital acquisition. And then the first thing is to understand how to investigate that. And part of the investigation is understanding who on the ward may be sources for infection. And then at the same time, implementing measures that will reduce the risk. So it doesn't necessarily mean that every hospital healthcare worker is wearing an N95 all the time, every day. But it does mean that when you have identified increased signal of risk, for example, a probable hospital-acquired case on that unit, and for those healthcare workers taking care of that individual, that should alert them that this is an increased risk, and services such as infection prevention and control should start making interventions with their facilities partner in, first of all, ensuring healthcare workers have the adequate personal protective equipment, which in this case will be a respirator, to ensure optimal filtration of the air the healthcare worker is breathing. And at the same time, short-term measures such as placing portable HEPA filters in those rooms that have identified cases will help this from propagating, because you can have unidentified healthcare workers or other patients who may still have disease but haven't been diagnosed yet on the testing. So these type of measures are all added layers that will help reduce risk in that hospital setting. In a COVID ward, for example, a unit used to hospitalize only patients with known COVID, the risk is not that everyone on that ward is at the same level of transmission risk, because people are at various time points in their illness. So if you move someone there who's just acutely diagnosed, that person is going to be at very high risk of transmitting to others. So that's why those measures need to be more significant in those patient rooms. Whereas on the rest of the ward, you will have a basic level of environmental improvements that should reduce aerosol transmission, as highlighted in the slide deck, and then further more rapid identification of individuals in that area who are infected, and personal protective equipment for healthcare workers. Now, if we translate this to different areas, it is hard because we can go into grocery stores, movie theaters, or even hockey games. Now, we've heard that hockey games are going to be open. We really have to understand the environments that are going to lead to highest risk. And it's very clear in the last 19, 20 months that those super spreading environments are well characterized. It's when you have a large group of people together, hopefully, especially if some are unvaccinated at higher risk, bringing in this infection in their asymptomatic phase, this can lead to super spreading events when the environment is close contact with individuals, because you're in close proximity with lots of aerosols, poorly ventilated areas, or for example, in hockey games or ice rinks, there is differences, and you would have to defer to the engineering experts to speak about the differences on why transmission risk and CO2 levels may be higher. And it has to do with the temperature as well as airflow within rinks or large places like this. So it is important to understand those characteristics that can lead to super spreading events, and then add in measures that will hopefully reduce risk. It's not possible to reduce risk to zero, but by reducing transmission risk, we are able to bring down this epidemic from exponential growth.
Thank you so much for that very thorough answer. I think that was really informative. And I think it's a good segue to perhaps our next webinar, where we'll be talking about rapid tests and how that could be maybe utilized in things like hockey games and things like that. But now I see that we do have Mary Griffin from Czech News, who is available to ask a question at this time.
Great, thanks very much. I know that PoP Alberta started because doctors in that province were upset with how they perceived the handling of the pandemic by the Alberta government, and that's led to an exponential rise in cases. But I don't get the same sense of outrage here. Like, I'm just wondering the rationale behind starting PoP BC. I know we're seeing this huge increase in rise of cases, but that is connected to the majority of people's decision not to get vaccinated. And then just a second part to my question as well too. I'm just wondering about the aerosol transmission. If it is aerosol transmission, would we not be seeing more cases in the elementary schools? For example, Dr. Henry talked about 8 clusters resulting in about 300 cases in Fraser Health, but those groups are remaining low at about 3 cases per cluster. If it was in fact aerosol, wouldn't we be seeing more cases in the classroom? Thanks very much.
Yeah.
Thank you.
Can I take the second? I'll take the second
Yeah.
question, but I'll let
Sure.
someone else answer the first question.
Yeah. So, Dr. Zeiler, do you want to answer the first question?
Sure. So, I think that yes, Alberta, there's some differences between Alberta and BC, but really, when we, as I was mentioning in my introduction, when we look at where we're at in our 4th wave, even though there has been some plateauing of the overall numbers in BC, when, as Dr. Tan mentioned, with those first graphs, they're still exponentially rising in the north of BC. So as you remember a bit more so at the beginning of the pandemic when we were saying we're all in this together, remember that? Well, I think we're still all in this together, and the way that manifests is that we're having to fly people from up north who need ICUs down to other parts of the province. So even though it may seem like we're sort of out of the woods when it comes to our pandemic, I don't think that that's an accurate picture, and there's still a lot of death, a lot of morbidity happening that needs to be addressed. And with doing these briefings, we're trying to explore some of those things and bring a bit more information to people to be able to do that.
Thank you. And what I'll add also is, right now we might be able to, as a healthcare system, as an entire province, hold on to the level right now, but we're on a cusp there. We're on our 4th wave. Healthcare workers have been going through this for a very long time. We know we're working with short-staffed groups everywhere, and we can't actually afford to be burning out our healthcare workers and also sustaining this high level of acute care need without longer term effects with regards to patients who need healthcare for any reason, COVID or not, if you're in a car accident, if you have cancer. And so it's really about, how do we actually bring down all levels of transmission, knowing that we have vaccination rates that we need to target. But until there's a higher vaccination rate, there's going to be higher community transmission. So there's things that we all can do as being all in it together to be able to actually try to bring it down within our communities. And Dr. Long, I'm just going to give you.
Yeah, to address the second question, I think that is a common confusion of the ideas about transmissibility or infectivity, infectiousness, specifically transmissibility and mode of transmission. So earlier on, as I said, people said, well, it can't be airborne because it's R naught or reproductive number, the average number of individuals that one person infected then goes on to infect is much lower. Well, we've seen that that's not the case with Delta specifically. We've seen an increase in the reproductive number. One person can indeed infect many more individuals. But what's unique, quite different about this virus compared to, say, influenza is that the dispersion factor, meaning this is an overly dispersed virus. Not everyone, this is an average when we talk about reproductive number and the number of individuals one person can infect. Not everyone will affect 10 people. One person might infect 80 people, and someone else might not infect anyone at all. And it has to do with multiple factors. When we talk about mode of transmission, it is directly referring to inhalation of aerosols that contain the virus or viral-laden aerosols that then lead to infection. It doesn't equate to how many people can be infected or the transmissibility of this virus. And so I think that's one important concept to really clarify, that mode of transmission is not equal to how infectious or how transmissible this is. But mode of infection is fundamental in knowing what measures are important to allocate our resources to. to both prevent further transmission of this and also in the future understand how we deal with future respiratory pandemics. Our ability to be prepared now will help us in the long run so that we don't make the same mistakes that we have when dealing with the new emerging respiratory virus. And I think that was very clear in the SARS Commission about what needed to be done and taking the precautionary principle. I mean, even if we are completely wrong on that possibility, I think the evidence doesn't suggest that, but even if we were, all the things that we're doing now are preparing for and also improving building resiliency to indoor and air environments and how they could be healthier for us, both in terms of infection and other health factors, because we know that particulate matters that are inhaled can contribute to other diseases like lung disease and long-term diseases that affect overall health. So all those things that we now recognize, we were able to combat viral borne diseases through that are bloodborne, transmitted through infectious fluids, able to combat waterborne pathogens, and now what we need to do is be better prepared to combat airborne pathogens.
Great, thank you so much. We're going to try to squeeze in actually, okay, we have one last question that I actually had that was texted to me because we are over time. Dr. Long, what is your understanding of BC government's stance on aerosol transmission?
I think it is, from what I've read, it is, it doesn't give you the full information, and that's why I think pointing people out to some of the other resources available will provide a fuller picture. I think that in British Columbia, we still might be fixated on some of the guidelines that have been established. And I said early on, I was one of those individuals who mistaken how things were done. And that had to do with our medical training, what's in textbooks in infectious diseases, infection control, public health. All that was informed by some key figures throughout history that may have swayed and overly influenced on how we think about how transmission works. So when we look at some of the guidance coming up in the province, many of the guidelines still focus a lot on interventions that may only be effective in combating a pathogen that is transmitted primarily through the droplet and contact route, through fomites or direct contact. It does not have enough emphasis on addressing the main mode of transmission. But I think that, it took a long time for us to recognize tuberculosis. It took us a long time to recognize measles and Aerosol zoster virus as being airborne transmission as a key component. Hopefully now, with all the things that are going on and all the multidisciplinary science that's contributing to it, we can respond to this faster.
Great. Thank you so much for that answer. And I think it really underscores how we are learning that it's not just medicine as a discipline, it's really multidisciplinary engineering, atmospheric science. And I think it also underscores precautionary principle. If we have an inkling, we need to be prepared so that we can actually be heading this off as we can. So thank you so much for this. We have actually gone over time, so I do apologize. But thank you for coming to Protect Our Provinces BC first webinar on aerosol transmission of SARS-CoV-2 that causes COVID-19. We will be having another webinar next week, same time at noon, I believe, on Wednesday, the 27th, October 27th. And we will be talking more about other issues, rapid tests. We're going to be talking about marginalized populations down the road. So stay tuned. Check out our website, protectbc.ca, for the latest and greatest information. We will also be touching base with Michelle Naef, and hopefully she's okay and was able to evacuate and get some of her last slides on, or at least information. There is now new information and articles to be able to kind of fill out the information that has been discussed today. And if you have questions, please engage with us on social media, and we will try to answer some of the questions over time, either through social media or at our webinars. So thank you very much for tuning in, and we hope to see you next week. Take care, everyone.